Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith Rogers. Welcome back to this special series of Public Health in the Field dedicated to addressing the Black maternal health crisis in the United States. Before we begin, be sure to check out the first 2 episodes, which cover how and why the nation came to a new reckoning with deep maternal health disparities in recent years and how government policy can provide solutions. To conclude the series, co-hosts Dr. Rachel Burvell and Annalise Winnie will explore the revolution in maternal health that's happening outside the policy space, but that also informs it. They'll investigate how Black moms, community advocates, and a new generation of medical trainees are taking this issue into their own hands and how everyone can contribute to solutions. And a quick note about the language used in this series. While we use the terms maternal and women throughout the podcast, we acknowledge that not all individuals who give birth identify as women. Let's listen.
On Mother's Day 2017, Johnna Benjamin found herself fighting for her life, just days after giving birth to her second child, a baby girl. Her dangerously high postpartum blood pressure was a stark reminder of the dire maternal health outcomes faced by many Black birthing persons in the United States. As she lay in the hospital at just 32 years old, Johnna worried that she would become a statistic, leaving her 2 daughters motherless. Thankfully, she would survive. But this wasn't the journey to motherhood she'd come to expect.
I had taken all the classes and understood really well how to care for my child, but did not have a really good expectation of what would happen to me. The physical toll that pregnancy takes on your body was not something I had ever heard communicated in any circle. And so you kind of go into pregnancy expecting like that TLC baby story. If you remember the show, like it's going to be this kind of everybody's at home and we're all smiling like, everything's great. It's not this glamorous social media worthy experience all the time.
And like Shalon Irving, the top CDC scientist who died after giving birth to her own daughter that same year in 2017, Johnna's work prior to having children had focused on health disparities. She was well aware of how dangerous birthing can be for Black women in America. Her first child had been born prematurely, an outcome that's also more likely for women of color. So when it came to her second child, she was considered high risk and her care team took extra precautions. She had weekly injections of a drug called 17P, which was designed to prevent repeat preterm births. And just a note, that drug was actually taken off the market this April after studies failed to demonstrate its effectiveness. When she went into labor with baby number 2 at 38 weeks, and that's almost full term, she thought she was in the clear, and the birth went pretty smoothly. But afterwards, her blood pressure kept spiking, a possible sign that she was starting to develop preeclampsia, a dangerous condition characterized by high blood pressure. And she received excellent care to manage that condition. While she was in the hospital, the medicine she needed was brought to her bedside. And when she was discharged, those helpful medications were provided to her so she didn't have to go to the pharmacy on her way home. She was given clear instructions on how to take it and a blood pressure cuff so she could monitor her blood pressure at home and call the hospital if it got too high.
So really giving the type of service that every woman deserves.
Then on Mother's Day, 2 days after returning home, her blood pressure spiked again, and she was landed back in the hospital, where her readings were sky high, 190 over 100.
People were moving with the urgency of like gunshot wounds. And the doctor who was taking care of me came in the room. Just the look in his face, I knew like we were in big trouble at this point. And that is when I understood that my life was literally in danger and that was not something I had ever imagined and that I could literally die before the end of the night.
But she didn't. Doctors were able to stabilize her. She was eventually sent home with new medication. And when her blood pressure spiked yet again a month later, her care was escalated. She was referred to specialists who could help her in the long term. She knew she was incredibly lucky. As a health disparities researcher, she knew that a kink in the system at any point in this process could have cost her life. Because for so many women, it had. So at the time, she told us,
my public health mind is rolling. Like, my first thought is, what did I do wrong? Where did I go wrong? And so as I'm trying to understand, and I'm seeing I did nothing wrong, I'm a part of this huge number of women who, some unlike me, don't have the ending that I have.
When she looked back on the experience, she realized
I had all the care and all the right people saying all the right things at all the right times, but I lacked the understanding of how serious this was, and my community lacked the understanding of helping me understand. Like, we are also conditioned to keep going, or to use phrases like, oh, you're just pregnant, or oh, you just had a baby, or to ignore when our friend says, oh, my head really hurts, or oh, my feet are really swollen.
Which, by the way, can be normal pregnancy symptoms, but they can also be signs of hypertension.
Throughout this process, I felt like I was wearing this cape. I didn't intend to put it on, this like superwoman cape. Like, I can be a mom and a wife and like a literal boss. Like, at the time I was the leader of a department. Like, I can do all these things without acknowledging the fact that I'm pregnant, right? Like, I'm gonna just do them as if everything is normal, not realizing how unrealistic that was.
Janae quickly learned that she was far from alone in this experience. She and the loving community around her had been conditioned to look at pregnancy a certain way, to push through pain and write off a lot of worrying signs as part and parcel of pregnancy.
In retrospect, I think that's something that is built into us when we think about enslaved women who felt that their value was very much tied to being able to give birth with ease. And so they express no discomfort. They don't give off in any way that this is a challenge for them or that something could happen. And I think that gets passed down generationally. Whenever I teach, I always say that culture is learned beliefs and behaviors. So it's not that anyone is intentionally trying to teach you to ignore yourself, but just based on experience, that is the messaging that gets ingrained in you. And it's hard to undo that.
There was a clash between the expectation that she could endure the challenges of pregnancy and the reality that, as a Black woman, she was actually at higher risk. She needed more care, not less. This brings us to the concept of weathering, which acknowledges how generational trauma, strife, and hardships can be embedded in the body. The concept was coined by Professor of Public Health at the University of Michigan, Arlene Geronimus, in the 1990s.
Weathering is what happens to human bodies down to the cellular level when they grow, develop, and age in a systemically racist, classist, sexist, religiously intolerant, gender binary, or xenophobic society. Weathering leaves members of oppressed populations more likely to die or suffer chronic disease and disability long before they are chronologically old.
This idea is supported by a growing body of research that shows that Black women have higher rates of maternal morbidity and mortality, even after controlling for socioeconomic status, education, and other factors. The cumulative physical and emotional toll of racism can lead to the early onset of disease and a wide range of conditions, including postpartum hypertension, like that which Janae experienced. Weathering also showed up in the strain that came with assuming that she should power through pregnancy and childbirth unscathed. She's now committed to helping other women avoid the same experience. Today, she is a student in the Doctor of Public Health program here at the Bloomberg School, as well as a committed maternal health advocate and postpartum doula. Her LLC, Mommy Moments, provides resources and support to birthing women and the communities who help care for them. Janae's story and the advocacy it inspired is just one example of how community-based organizations and grassroots efforts are helping address the Black maternal health crisis in myriad ways. They range from focusing on providers and the systems directly caring for Black patients, empowering communities and initiatives where Black patients live, and supporting Black patients themselves at the individual, local, and organizational levels. In our previous episode, we outlined how government policy can be instrumental to improving maternal health. From expansion of Medicaid to paid parental leave, from data transparency to telehealth, to passing the Momnibus currently in Congress. However, policy is just one piece of the puzzle, and not the only driver of change. Some other pieces of the puzzle: understanding the history of racism in the healthcare system and how many have worked to overcome it. That's what we'll be talking about today. Veena Smith-Ramakrishnan, Senior Policy Associate at the Century Foundation, explains.
A lot of these issues are really deeply baked into the healthcare system, especially when it comes to the bias and racism that we're seeing.
Acknowledging how ingrained racism is in our society requires an honest appraisal of history. Let's start with the Flexner Report, published in 1910, a study on the state of medical education in the U.S. and the inspiration for medical education as we know it today. That report was funded by the American Medical Association, and it led to the closure of all but 2 historically Black medical schools, leaving Black doctors and healthcare providers with fewer options for education and professional development. It also resulted in severe shortages of Black health professionals that we still see today. This, in turn, has contributed to a lack of cultural humility when caring for Black patients. The undermining of midwifery practices, too, is evidence of how American medicine, as it sought to legitimize itself in the early 1900s, did so at the expense of Black healthcare providers. Granny midwives were highly regarded women who were led by principles of holistic, compassionate, and spiritual care, and in the process, provided for and attended half of all births at the beginning of the 20th century. But slowly and gradually, Black midwives were excluded from developments in the reproductive healthcare space. By the 1920s, legislature intensified the attempts to control midwifery with the goal of eliminating the practice. With new regulations, midwives were required to obtain permission slips from licensed doctors to give prenatal care, and obvious barriers and obstruction to the services they once easily provided. With sexist and racist overtones, the practice of midwifery was discredited. By 1975, less than 1% of births were attended by a midwife, as hospital births became the healthcare standard.
And that's not an accident.
That's Inez Khalida Mari, Vice President of Equity-Centered Capacity Building at the National Birth Equity Collaborative.
That's something when you decimate a population, when you decimate the profession, right? When you restrict the number of schools that are available to study midwifery, where you ban traditional midwifery, you're going to see a shortage in healthcare workers who can fill that slot.
So as time went on, the stark inequities that resulted from this emergence of regulated medicine became harder and harder to ignore. Eventually, groundbreaking research began to track the problem. 1985 was a major turning point with the release of what was known as the Heckler Report. It was the first federal report to acknowledge the existence of significant disparities in health outcomes based on race. It reported that Black people were dying at much higher rates than white people from a range of illnesses, and it acknowledged that these inequities were the result of a complex interplay of social, economic, and environmental factors. Then, in 2002, the Institute of Medicine released a report titled Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare. This report made a number of recommendations, including increasing diversity in the healthcare workforce, improving cross-cultural communication, and increasing funding for research on health disparities. A few years later, in 2008, PBS would broadcast a 4-hour documentary series, Unnatural Causes, examining the role of social determinants of health in creating health inequities and disparities. For maternal health advocates, this was highly anticipated viewing.
I feel like Unnatural Causes was the big, we need to put that in the Hall of Fame for what really brought people to understanding what issues of health equity look like, right? That I remember, when I was working on my master's degree, at UAB in Birmingham, I remember when Unnatural Causes came out, it was like we were like a pep club. We were inviting our friends from everywhere. We had like popcorn, and it really helped to bring, I think, the message of why we're in public health.
These pieces were groundbreaking for their time, and the findings felt new, but they actually were not the first to demonstrate that racism led to poor health outcomes. There had been scholarship, almost a century prior, that drew similar conclusions, but at the time was largely ignored.
We're talking about the work of W.E.B. Du Bois, the iconic sociologist. In 1899, he published The Philadelphia Negro, a trailblazing piece of research that detailed racism as a social determinant of health. While he didn't use these terms, his research sowed the seeds of what are now well-known concepts like structural racism and health disparities. However, it was sidelined in favor of theories from white scholars, theories that focused on the false premise that racial differences were rooted in biology. Du Bois's conclusions are now being rediscovered in public health circles, which is a good sign. But as Dr. Rachel Thornton, Associate Director for Policy at the Johns Hopkins Center for Health Equity, explains, it should never have been forgotten in the first place. She and her colleagues have called for his work, and that of other Black scholars, to be recentered as essential texts across the field of medicine. We asked her to ponder what training might look like for medical professionals if it had never been overlooked.
What would the academic workforce teaching them look like if Du Bois were part of the canon? Like, what else would have changed in the system for that to be the case, I guess, is kind of where I landed. And I think that's our constant journey, is that evolution is a comfort with ensuring that we're not blinded by a predominant perspective or an echo chamber. And I think if that were the case, if his science were central in the education of every nursing, public health, and medical student in the US, there would be something different about the academicians, the professors, the teachers responsible for that than the academicians, professors, teachers we have today. But I think that evolution is underway, and I think a lot of people are learning about it.
While this evolution is underway, in the meantime, inequitable care models are still a reality in the American health system.
For example, think about the excessive drug testing of Black women on labor and delivery wards. In April, the New York Times highlighted a study from Pennsylvania hospitals. It found that Black women were less likely to test positive for drugs than white women, despite being targeted for testing more. This led the authors of the study to urge hospitals to re-examine their drug testing practices in order to address racial biases. Dr. Jamila Parrott, President and CEO at Physicians for Reproductive Health, describes it further.
Those are policies that are deeply misinformed, misguided, not grounded in science or medical evidence, and in fact, are directly misaligned with principles of public health, but are being put into practice on labor and delivery and birth centers around the country every minute of every day. And that's something that I think we all need to come to grips with, because it forces us to move differently in this space. It's recognition that we are not infallible. We will make mistakes and we will cause harm. And the question becomes, what do we do after it? So when we look at the role of healthcare providers in this chain of events, we are at the beginning. We are the inciting factor here, right? It is us that has started this whole thing in motion. And so it's important for us to understand that our responsibility, our role here is key.
A new generation of medical trainees are heeding that call, and in many cases, they're leading the charge towards putting equity front and center of their education. Dr. Neil Shah, as a Harvard Medical School assistant professor, can attest to this.
It's interesting. Like, one of the things I've seen in the last couple of years is that medical students themselves are a big part of driving the change. They're the ones who are calling for implicit bias curricula or calling for, health equity to be part of the curriculum.
Some of these efforts push for curricular changes. Others engage with the wider movement to acknowledge racism as a public health threat. And medical trainees have become more involved in anti-racism activism through groups like White Coats for Black Lives.
For example, in 2020, protests erupted at medical schools across the country in response to the death of George Floyd at the hands of Minneapolis police, including here at Johns Hopkins.
Academic medicine is a community just like everywhere else, and we have to hold ourselves accountable just like everyone else. We need to show solidarity with the movement, asking all of us in our communities to denounce police brutality. I think that overall, we are all very, very, very shocked and tired of the continuance of police brutality, of health disparities, of health inequities.
That's Dr. Thomas Elliott, speaking at a White Coats for Black Lives protest when he was a pediatric resident at Johns Hopkins Hospital. Today's medical trainees understand that it's crucial to address the historical and systemic issues that have led to health disparities, and their voices are getting louder and louder.
It starts with us, it starts with the people, it starts with the smallest grain of salt. And we have to make sure that everybody feels empowered to call out those types of things and bring it to light, because only then we'll be able to make the progress that we want.
So while it's essential to get loud about systemic health inequities, when it comes to dealing with patients, medical practitioners have to hone another skill.
It behooves us to listen to what's happening. In order to do that, we have to be quiet. Listening is the hardest thing, and it is the least taught skill in medical school and in medical education, that listening piece.
The emergence of students transforming their training has been a positive development. More institutions are recognizing this need and taking steps to diversify the healthcare workforce too. This includes increasing the number of trained and employed health workers of color. And by having a more diverse workforce, patients can receive care that is more sensitive to their cultural context and better tailored to their specific needs. This, in turn, can help to improve health outcomes and reduce health disparities.
We talked about the workforce opportunities, but it's not just medical students or nurses. I'm really, really excited about the possibilities to expand access to doulas and midwives.
Studies show that people who receive care from midwives are less likely to have a preterm birth, less likely to have a C-section, and more likely to breastfeed. Additionally, midwives are more likely to provide patient-centered care. Doulas can also play a critical role in improving maternal health outcomes. Doulas are non-clinical healthcare providers who offer physical, emotional, and informational support during pregnancy, labor, delivery, and postpartum. They provide a range of essential services. They help empower mothers to advocate for their healthcare preferences, facilitate communication with healthcare providers, and provide assistance to many changes associated with birth. And studies show that their support is effective. Mothers who work with doulas are more engaged and satisfied with their care. Doula care is also associated with fewer birth complications and a reduced risk of having low birth weight infants.
So those are the kinds of possibilities that I see, with the caveat that I think there is a movement right now in our country with a proliferation of community-based organizations focused on birth equity, and that's really, really important. Health isn't produced in the four walls of a clinic. It's produced in people's homes, in their communities, in their workplaces. And you have to not only have the right technical expertise to serve someone, you have to have the right lived experience, particularly when it comes to childbirth.
These programs have been started and led by Black mothers deciding to take solutions into their own hands. Black mothers like John Benjamin, who we met earlier.
And so I developed an LLC that's Mommy Moments.
She's talking about the organization she started in response to her own lived experience. Mommy Moments started out providing support to women she knew, providing information on how they can care for themselves during their pregnancy, like eating and sleeping well or resting, and educating them about how doulas can play a role in their healthy pregnancy. Those are the grassroots efforts, but she's also working at what's called the grass tops, so targeting established and influential groups and agencies.
Reaching out to the Department of Health and being invited to be a part of the different things that they were doing, it gives me an opportunity to work in the policy side that I really like, while also through Mommy Moments being more rooted in the community and sharing that information.
But it's not just the people directly impacted by the Black maternal health crisis who have the potential to advocate for solutions. All of us, including you as a listener of this podcast, can be a part of the solution. Dr. Shaw recalled a conversation with Loretta Ross, one of the mothers of the reproductive justice movement.
Your job is to make sure the chain doesn't break at your link. And what she said to me is that, when the world is a mess, you should grab a broom and clean where you are, which I thought was really, really powerful.
So solutions are at play at all levels of society. There is promise in policy, potential in system change, and renewed energy with the next generation of medical trainees. Communities are using collective effort to transform experiences. Families affected by the crisis are raising their voice.
And that leads us to the individual, no matter who you are. Because you don't have to be a policymaker or a physician or a Black birthing person to help solve this problem. We all have the power to help.
So here's a call to action. And don't worry, you can put your pens down. All of these tips and more are available on the resource page linked to the episode description.
First, you can get your hands on books written by any of the mothers of the reproductive justice movement, or any books on medical history like Under the Skin by Linda Villarosa.
A book that is not focused on Black maternal health, but is absolutely integral to our understanding of the legacy of racialized medicine in this country is Harriet Washington's Medical Apartheid, where she really writes about this and brings the story together in such a cohesive way.
You can educate yourself to take action.
Look at a long list of resources or things for people to read, depending on who the groups are. If they're philanthropists, if they're researchers, if they're community programmers. If you go to Black Mamas Matter Alliance website, which is bmma.org.
Another way to get involved? Consider supporting organizations that are doing the work to stop maternal mortality and are empowering families and their wellness. Groups like the National Black Midwives Alliance and the National Black Doulas Association, organizations like Mama Toto Village in DC, the Bloom Collective in Baltimore, Forkira for Moms, founded by Charles Johnson, who himself lost his own wife after a postpartum hemorrhage, or organizations led by the guests of this podcast. Support with your funds or volunteer your time to their initiatives.
It's also important to acknowledge that improving Black maternal health goes well beyond just reading and donating to organizations. It requires advocating for policy change and examining and challenging our own biases. We encourage you to cast your vote for maternal health. For example, you can support politicians engaged in maternal health issues. And you can call on politicians who are not supporting legislation to improve maternal health to do so.
Also, you can educate yourself about the social determinants of health and rethink the notion that individual behaviors are to blame for poor health outcomes. Research shows that a lot of Americans are not aware of how social determinants of health actually impact our well-being.
And honestly, I think some of the most powerful things that we can do are just in our own spaces and communities by making sure that we're doing a good job of seeing and hearing the people around us.
You can also share what you've learned from our series on social media. The Bloomberg School's Instagram and Twitter accounts have shared some infographics specifically made with this series in mind, and we encourage you to amplify those.
And finally, it's important to acknowledge that there are stories we can celebrate. Smith Ramakrishnan reminded us of that.
Celebrating the small wins when you get them, leaning on community, and also focusing in on those stories of joy. There are a lot of success stories. There are a lot of people who are able to have compassionate, respectful birthing experiences filled with joy and positive emotions.
So there is hope, and we can educate ourselves, advocate for change, support organizations working to improve Black maternal health, and challenge our own biases. Dr. Parrott said it so simply.
There are many places where folks can step in. I only ask that you step in. This work belongs to you too.
And with that, thank you for learning with us and listening to this special series of Public Health in the Field. I'm Annalise Winnie.
And I'm Rachel Burvell. Until next time, stay well.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinale, Philip Porter, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Fernandez and Shian Briscoe. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.